Welcome to the Evidence-Based Practice and Identifying a Clinical Problem My Translation Rules presentation. I'm Dr. Shelley Wilkinson, a Queensland Health Research Fellow from the Mater Health Services. The key learnings from today's presentation are to challenge your own approach to how you practice, to gain an understanding of your barriers and enablers to evidence-based practice, not only in a generic sense, but about a specific clinical problem you have or will detect, and to learn an approach to follow to determine a clinical problem in your work area. To set the scene, evidence-based practice, or EBP, in allied health has emerged from evidence-based medicine. EBP is recognised internationally as a valuable construct in the delivery of high-quality, cost-effective health care. It's underpinned by clinicians' knowledge and experience, plus the evidence available from good research, and importantly, the values and needs of the patient and the context in which the healthcare is being provided. It's well documented in the literature that there's not been universal adoption of EBP across allied health. So how do I know what I do is effective? Are you delivering evidence-based care? I'm going to run through a few scenarios and I want you to think if any of these are relevant to you, and maybe not a show of hands. I know what I do is effective. I learnt it at uni. It's the way my supervisor taught me. It's what we've always done here. It's what they do at that hospital over there. We're really busy. We do lots of reviews. We're catching everyone. We're doing what the doctors want us to do. We think we are, but we don't really have the time to check or review or evaluate because we're too busy. Ba-bow, no deal. I'm sure there was a yes in there for many of you, and perhaps you are delivering evidence-based care. But the purpose of this talk is to help you ensure that you are effective and you can demonstrate this. So why might we not deliver evidence-based care? From the literature, we know that practice and decision-making is often based on experience and familiar actions rather than research evidence. For the most part, practice is ritualistic compared with evidence-based, and even in areas where there is clear evidence, this is often the case. Many people believe research is important to apply to practice and that it has the potential to improve the quality of care to patients, but also it's been reported using and applying research findings to practice can occur less than 50% of the time, and the longer someone has been working, the less likely they are to use research in clinical practice, and they had worse attitudes to research. So more work is being done around allied health and dietetics and EBP, and a lot of the original work that I'm presenting on the screen here has been done more in medical and nursing populations. The last point is relevant in dietetics, was less relevant in dietetics, with many more experienced dietitians having higher research degrees and are engaged in research, so that's probably not as applicable to us. So the first activity that I'll get you to do is a quick tick and flick. So I'll get the facilitator to pause the slide here. You're going to do a barriers and enablers self-assessment activity. So I'm going to get you to think about the barriers and enablers to EBP that you face. That's the first activity. Spend a few minutes going through this now when the video is paused. The second workshop that I'm going to get you to do is one to start now, but continue with your team. Please don't do it by yourself, although it would be quicker, and you probably do feel you know the problem in your work area. So maybe start to jot some ideas now to generate discussion with others. Sitting down with not only other dietitians, but other clinicians, patients, admin, food service staff, etc., etc. And that will really help you work out what barriers exist to you delivering EBP in your clinical setting. By the end of this presentation, your idea of what your clinical problem is, or how you'll find out what it is, may be different, so don't get too involved just yet. Doing this will also be an excellent start for your My Translation Rules project. The second activity that I'm getting you to do is based on the National Institute of Clinical Studies, or NICS tool, and NICS merged with the NHMRC in the 2000s, and it's an awareness of these barriers that will be the step that you take before deciding on the intervention, which will be covered in the implementation presentation, which will be coming up. So be sure to target your intervention to your barriers. Okay, press pause and get to work. Back again. So how did you go with that checklist? The barriers to EBP have been documented quite substantially in the literature. There's individual barriers, organisational barriers, as well as overlapping barriers. Individual related barriers include a lack of knowledge, skills, motivation, funding and direction. Organisational ones include those of lack of time and resources, library facilities, internet access and supportive managerial and research resource staff. A key barrier regularly identified is that many clinicians feel ill-equipped to translate EBP into the clinical setting. But as Batman says, if you don't have time for evidence-based practice, then don't practice. On the flip side, enablers to EBP have been shown to include more time to read, apply and do EBP in a purposeful, targeted way that relates to a clinical problem in an area that you're working in. This must be in an integrated, systematic way within routine clinical activities. An interesting paper published recently investigated barriers to EBP across allied health and included Judy Porter, a dietitian, as one of the authors. They found that while clinicians held a positive attitude towards EBP, there was low participation in EBP. Clinicians and managers didn't value EBP highly, or didn't value or view EBP as a core component of clinical care, with many activities directly related to maintaining patient flow viewed as higher priorities. There was also documented that there were a lack of skills and resources and difficulty associated with implementing evidence into practice as a further barrier. Interestingly, addressing EBP through small group projects rather than considering it to be an individual responsibility was more acceptable to clinicians and managers, and this approach has been used at the MTR over the last few years in dietetics. And this came out of a larger allied health EBP project that I'm going to present some data around now. And then I'll step you through how we managed the EBP small projects within the department. So across a number of years in allied health at the MTR, we looked at EBP self-efficacy, outcome expectancy and use in the allied health staff. And what I'm going to show you is some data around EBP use. We asked staff at 3 time points, how often in the last 6 months did you practice evidence-based practice relating to a specific patient? And then how often do you identify a clinical problem, generate clinical questions, track down the best evidence, critically appraise that evidence, apply that evidence, measure your outcomes, and then share with colleagues that evidence? And what we found was very similar across all of allied health, and these bars show all of the allied, this graph shows the allied health scores, but it mapped very similarly to what dietetics was. So again, to remind you, it was on a scale of 1 to 10, and so how often did you practice evidence-based healthcare is question 1, and then we see the rest of the questions, the process of EBP from 2 to 8. And what we found was lower scores for EBP question 3, how often did you generate a clinical question, how often did you critically appraise, and how often did you measure the evidence relating to a patient's care. And this is where we then targeted training for staff across allied health to try and increase these scores. And what we found over time was increases with the bars with the arrows above them, the significant increases. So just as a reminder, question 3 was generated a clinical question and we saw an increase over time. Well, we actually saw increases from all of the scores over time, but the significant ones were question 5, 6 and 7. So we did see an increase in people generating clinical questions, but significantly more staff critically appraised the quality of the evidence, applied it, and then measured outcomes. And the lowest ones here are really what we find across the board, and what the literature says the lowest scores are for all of allied health. Many people identify a clinical problem but don't generate a clinical question. They track down evidence but don't critically appraise it. They apply it but then don't measure their outcomes, and then they share their evidence with colleagues. So sometimes people are doing it and just don't recognise, but these results are quite consistent across allied health and in the literature. And so this in part is how we've designed the content of the My Translation Rules PD sessions. So that takes us to the question 3, one of those first steps that isn't done so well in delivering evidence-based practice is identifying a clinical problem. So another way to look at a problem is with a term that's commonly used, the evidence practice gap. So understanding what should be done and what is done and how much do these two differ. So an evidence practice gap may come from the emergence of new evidence, a top-down approach, e.g. the release of new guidelines or new knowledge, or a perceived quality problem, a bottom-up approach, and that's the first and the second line. So starting from the top, if there is new evidence, you can investigate whether this knowledge is applied in practice. If all is well in the world, you go up to yes, the green dot. Monitor your outcomes, preferably using routinely collected data for all relevant variables to prevent you straying from practice. If improvements are required, you find that you're not delivering care according to guidelines, then you do an implementation project following an implementation science framework, which will be a later PD session, and then evaluate the changes to see if you have improved the delivery of care. The bottom line, a perceived problem in healthcare, if you've observed a problem and best practice or clinical expertise is then drawn upon to inform the implementation strategy, and then you evaluate that. In some areas of healthcare there are weak guidelines, but clinicians still see a problem and want to improve care delivery. That's the bottom line going down to the no red dot. So this still needs to be undertaken in a systematic and planned way with a shared or team approach. However, it's important to note that this type of research is not appropriate for My Translation Rules submission, as it's more about generating new evidence rather than translating pre-existing evidence into practice. I'll step through a few more slides and then actually give you an example of dietetic projects that have followed different paths through this diagram. But first I want to take you through what we did at the MARTA in 2015, and this has carried through over the past few years. It was our department development project before we first undertook participation in My Translation Rules. So what we did was we all got together to look at what our service looked like. We decided then what we should be doing. So we did data collection and mapping, then we did something called BPIs or best practice investigations. Then we decided what the gaps, so our evidence practice gaps between what we should be doing and what we were doing. And then we prioritised projects which became our TRIP actions or our projects, our My Translation Rule projects. What we really need to start to do when we're looking at clinical, defining a clinical problem is the first two steps. What does your service look like? And then deciding what you should be doing. So the first step in deciding what your service looks like, we reviewed our activity of who we saw, how many patients we saw, how we saw them, how they were referred, if there were any models of care or pathways that we were using, and we also looked at how we prioritised them. This gave an idea of what we know and what we do, and this allows you to establish a rough baseline of activity. On the slide is some other things that you could collect. And where you might find this information, there's a number of sources. Data collection or audit as just described. You could draw on your clinical expertise and that of your peers. Reflection on your own practice, what works, what doesn't, what frustrates you, what needs improving. You could do purposeful reading in the area, not just random abstract skimming what crosses your desk in journals or tables of contents that are sent to you, but being critical about what you read and ensuring it links back to your clinical area. And the next slide will flesh this out a bit, but be sure to read systematically. Read systematic reviews rather than single articles due to what can be over or underestimated in single studies. More about this in Barbara's presentation. You can review guidelines, also assessing how applicable they are for your area. You can reflect on or collect patient feedback on the service you deliver. Collect staff feedback, awareness, knowledge, confidence of your service. And there may be other sources that you also use. So that's knowing what your service looks like, mapping it out. Then you need to look at what you should be doing before you can determine the gaps and the evidence practice gaps. So we called this our best practice investigations. The next step, the BPIs were done for each workload area across the MARTA department and that was completed in teams, but it can be done simply for each caseload. And we've used the NCPT headings of a DIME, assessment, diagnosis, documentation, interventions, monitoring and evaluation down the side to give a framework to how we recorded our BPIs. This is a useful guided process to specify your idea, to identify existing guidelines, and to allow mapping and comparison of processes and content for referral, assessment, documentation, intervention, monitoring and evaluation. So it's important to note a common problem. You look for evidence but find nothing. What should you do when there's no evidence or only very poor quality studies? This again links back to the bottom line of healthcare improvements diagram. If you've got the time, resources and skills, you create the evidence. It's also important to remember that the lack of evidence is very common in nutrition. For MTR, you should probably choose another clinical question where there's evidence to translate, but outside of MTR, and just generally with EBP, benchmarking across sites is a good place to start. Remember, MTR, My Translation Rules, has a multi-site collaboration prize. Or observing your own outcomes with an observational study would also be good. If someone has a project idea for MTR where there's no current evidence, they need to check in with a research fellow first before progressing, as it may not be eligible. So, let's look at the BPI steps. Documenting, obviously, the caseload you're evaluating. Do best practice guidelines exist? And then referral. Is there a set time, urgency for your area? How long should assessment take? And then assessment. What needs to be done in an assessment? How do you do this? Do you do other things? What do you need to change? What needs to be picked up? This should all be coming from the literature. Diagnosis and documentation. What information is essential to collect? Do you have access to this? If not, why? Can you get it? What are the usual PES statements that you would use in this area? Intervention. Are there guidelines around the most appropriate intervention or treatment for this patient group? Do you deliver it? What needs to change to make sure you do? Do you need more training? Do you need to introduce or develop a new program? Do you need to change the way workflow operates in your department? Monitoring. How often should you monitor? Are there no guidelines? Can you get together with peers to come up with a consensus and then evaluate? What should you monitor? At the end, with evaluation, we've got clinical and process measures for each caseload that we report on quarterly. That should come from the literature in monitoring and evaluation. And on evaluation on a larger scale, how do you know you're effective in this caseload? This should have at least one clinical and one process measure. You should measure essential elements from the list above, but don't be excessive. It should come out of the literature and be streamlined, and there should be hopefully more of this covered in the OSHI presentation about outcomes. And then research gaps. We have this at the end, so when there is the opportunity to undertake a larger project, whether it's a student or we've got funding, we know exactly what we want to do and ensure that the work being done isn't done in isolation and it feeds back into the service improvement and broadening the knowledge base. And it's quite clear in every area when people were reading the literature, gaps were identified. More research needs to be done in this area about ... So once you've worked through this and match up what was on the previous slide, your service mapping, with this to work out what your clinical problem or problems are, you follow, you can determine where your evidence practice gaps are. There may be few or there may be a lot. If there are a lot, you don't have to do them all, but you need to get together and prioritise what's maybe the best bang for your buck, or what's going to align with the organisation. Where will you get quick runs on the board if you do a project? It's a very systematic way, following the BPIs, to identify clinical problems in your service delivery. And that leads us to the healthcare improvements flow diagram again. So following the mapping comparison, you'll see we've got the gaps in the literature and also gaps in the service as per that diagram. So working from the bottom up, it's almost the hardest to the easiest, the perceived problem in healthcare and no evidence to versus yes evidence, and then new guidelines, no and yes to knowledge applied in practice. So for example, let's put some dietetic things around here, and I'm going to use Mothers because we've done a bit of work here at Mothers. So at the Mater Mothers Hospital in 2008, we opened a new hospital. We were only seeing a fraction of the women. We had 5,000 public, 5,000 private women coming through, and we had 1 FTE. We looked at the literature as to what nutrition behaviours influence pregnancy outcomes. We surveyed Australian services to find out what models of care were in use, none, and none that were evidence-based. And we also asked what women wanted and what did they look like, what was their age, weight gain, service access, awareness and dietary intake. So we've got a perceived problem in healthcare, we've got 1 FTE and we need to deliver best practice care. There was no evidence, so what we actually had to do in one case was design an RCT. We evaluated a group program designed to improve diet quality of pregnant women using evidence from the literature to facilitate behaviour change. We knew what women needed to know, and we designed a program that we thought would change behaviour to get women changing what they ate in pregnancy. So we created new evidence, and we then applied it in practice. If we go back, we created new evidence, yes, it changed behaviour, and then we went back, and then we went up to the yes, we're still on the bottom line. We had a program that we developed called Healthy Start to Pregnancy that we did in the experiment, and then we implemented it across the public and private hospital, and then we now deliver that program to all women, and we do implementation, interventions and evaluation. We just monitor the outcomes now of that program. So that's almost using one project to address two lines in the healthcare flowchart. If you had new guidelines, if we want to start on the top line, we identified in the Mother's Hospital that there were guidelines around GDM that weren't being followed. We knew there were guidelines in America that said if women were seeing a minimum of 1 new and 2 reviews, they would need less medication for managing GDM. An RCT had already been done, so there was evidence there. But when we looked at what we were doing at the hospital, it wasn't applied in practice. So we designed an implementation program, so going along new knowledge guideline, it's not applied in practice, so the red dot no, so we did an intervention of a model of care of GDM implementing into practice. Denise and Mel's case study that follows this presentation will use this framework to show how they identified and addressed a clinical problem in the NICU at Mater. Not to steal too much of their thunder, they detected a perceived problem in healthcare, a delay in infant feeding. They identified evidence around what should have been delivered, amount and timing, R&Is within 24 hours, and following a number of audits to find out how much babies were receiving, how soon or late they received it, and then an extensive barrier assessment, which you'll find out from them was not what they thought. They designed a TRIP project to address this and have had great results. When planning all of these projects, small or large, they should be informed by the BPIs, prioritised within your teams with team leaders and directors or other departments, and they should use appropriate frameworks, a topic of another webinar, but I'll just say, unless it's the rarest of circumstances, in-services and posters should not be used, or at least not in isolation. As with reasons our patients don't change, their diets or don't exercise, it's rare that it is a knowledge barrier that exists, but more of that in the following webinar and in Adrienne's case study. So I want to leave you with some questions and a reminder as you undertake this improvement work. I think we'd all agree that we're working to ensure our patients receive the best available prevention, diagnosis and treatment of their health problems. When coming up with what you plan to do, remember the problem does not contain elements of what you think the solution might be. What is the problem? We need more doctors, we don't have enough doctors, the waiting lists are too long. Bom, bom, bom. Patient outcomes are adversely affected by long waiting time. So the rule number 1 is don't make assumptions. The overarching questions as you assess your services with mapping and BPIs are, is good quality care provided? What are the problems? Describe them, what it is or what they are. Is it a real or perceived problem for one person or many? Is there a gap, not being done at all, or a mismatch, need to change current practice, or something else needs to be done? How do we improve care for patients, and what are the conditions for sustainable improvement? So I'll leave you with a thought from Seth Godin, and we'll be sending these out once a month. I'm not sure if anyone's heard of Seth Godin, but you'll be getting an update, or you will have received an update from Amy, and then you'll get our monthly post. So he's written in this blog post, so busy doing my job, I can't get any work done. Your job is an historical artifact. It is a list of tasks, procedures, alliances, responsibilities, to-dos, meetings, mostly meetings, that were layered in one at a time, day after day for years. And your job is a great place to hide. Because after all, if you're doing your job, how can you fail, get in trouble, make a giant error? The work, on the other hand, is the thing that you do that creates value. This value you create, the thing that you do like no one else can do, is the real reason we need you to be here with us. When you discover that the job is in the way of the work, consider changing your job enough that you can go back to creating value. Anything less is hiding. They'll be here these references will be here for you to look back on if you need to follow anything up. And then it's time for questions.